Good? Good. Okay. All right. So for those of you who don't know me, my name is Genenbacher. I am a recently graduated physician assistant working in the ICU now. I've been in the ICU for about 6 months. I graduated from SIU Carbondale's program, and then prior to that, I was a respiratory therapist for a few years here at Blessing as well. So today I'm going to start out by talking about CPAP. I think this presentation touches on BiPAP a little bit, and then I'll get into ventilators and kind of just a basic introductory / overview of vents. So start with the definition of sleep apnea. I had this presentation initially set up for SIU's residents, so it's kind of a little more geared towards outpatient stuff rather than inpatient, but a lot of it kind of overlaps. So obstructive sleep apnea is probably overall the most common use for a CPAP. Obviously, I mean, that still holds true for the hospital in the acute care setting. But in the critical care setting, that's probably a little different. We use it for more hypoxic issues and things like that. And we're looking in general more at BiPAP than CPAP. But just to start out with a definition of sleep apnea, intermittent apneas, hypopneas, and or respiratory effort-related arousals caused by repetitive collapse of the upper airway. So this is the most common sleep-related breathing disorder. Major risk factors include obesity, having an older age, being a male rather than female, any kind of facial abnormalities, and then let's see the last one, smoking, family history, things like that. So I have those listed down below. Go on to the next slide here. Signs and symptoms, just being sleepy overall during the day. Some of these are reported by the patients. Others, like snoring, choking, gasping during sleep, is often reported by their significant others. Morning headaches because that CO2 level builds up. And then physical exam findings, nothing super specific, but just, again, some clues that can make you think of that somebody would have a high risk factor for it. This I won't go too much into depth because it's more outpatient stuff. There's questionnaires out there that kind of lets you score patients as far as ordering it, when to order a sleep study, when not to order a sleep study. We'll skip to the better stuff as far as the stuff that relates more to critical care. Let's see, diagnostics. Sleep study is a gold standard. Generally, they could do a split night study, which means there's a portion performed during the a diagnostic section during the first part of the night, and then after that they follow it with more a therapeutic section where they're actually trying on the CPAP or BiPAP and messing with the settings. They do offer home sleep apnea tests. That's something that people use for whatever reason if they're unable to come in to a sleep study center and get an actual test done. So unfortunately, it's a lot less accurate, but some people with their insurances can't afford an actual sleep study, so they'll do an at-home test. And then finally, they can do a nocturnal pulse oximetry, which is what a lot of providers order here in the hospital, because obviously in the hospital, we don't have the tools to set up a full-on sleep study, so they'll just order a pulse ox overnight. Unfortunately, it can't really be used to diagnose sleep apnea, and even if the nocturnal pulse oximetry test is positive, then oftentimes they will send somebody for a sleep study test. So on its own, it's not really that helpful, but it's good for maybe ruling out sleep apnea rather than actually ruling it in. Next slide. This is just a picture of a sleep study. As you can imagine, when we are testing these people outpatient, it can be very difficult to get an accurate representation of what they normally sleep like with all these wires and controls and everything hooked up to them, not to mention not being in your own bed and very comfortable or anything else. So there's a lot going on. And then basically an EEG with a pulse ox, with muscle transmitters hooked up to the chest and the abdomen that kind of can detect different muscle movements. There's an airflow sensor. There's just a lot of stuff going on. This is just another picture of what the sleep study results look like. I'll just breeze through this stuff because this is, again, still more outpatient, I think. So the diagnostic criteria for sleep apnea is based on the apnea-hypopnea index. So an apnea, let's see, it's all based on time. I don't exactly remember the exact, what am I trying to say? The exact length of time that it has to be considered an apnea versus hypopnea. But basically, they do a calculation, and there has to be 15 or more obstructive events per hour of sleep. That's one way to diagnose this. Or you can have only greater than 5 with one of these following listed over here on the right, such as fatigue, sleepiness, waking up and choking, those types of things. So it's relatively pretty easy to diagnose. It doesn't really take a lot. And then the severity, again, the apnea-hypopnea index will be your go-to here. So let's see, here's apnea, a greater than 90% decrease for 10 seconds. That's what I was trying to recall earlier. I couldn't recall off the top of my head, but that's the difference between an apnea, whereas a hypopnea is a lot less of a significant decrease in airflow, again, for 10 seconds, but instead of a 90% decrease, you only have a 30% decrease in airflow. So not quite as severe as an apnea. And you have to have a 3% oxygen GSAT. So most of the times you're going to see hypopneas rather than apneas, but both can occur. And then you just score it based on the scale, 5, 10, 15, so on. All right, so definitions of different modalities. So in the respiratory world, we like to have a lot of different names for the same thing. So non-invasive positive pressure ventilation, also another term for it is BiPAP. And then CPAP is something different. That's continuous positive airway pressure. Another word for that you might see is EPAP. Trying to think of any others. Those are the main two. PEEP is also kind of used synonymously with CPAP, depending on who you're talking to. So the non-invasive positive pressure ventilation is kind of like an umbrella term. It includes CPAP, BiPAP, even bag valve mask ventilation. All those things kind of fall under that category, and then you can divide it from there. So with CPAP, the main difference is, for anybody who doesn't know, there's just one continuous pressure the entire time during inspiration and expiration. So whatever and it's measured, these are all measured in centimeters of water pressure. So generally of CPAP, anywhere from 5 to 15 is what most later in this presentation. And then PEEP is basically the same thing as CPAP, except when you're using invasive ventilation, this is the term they use. So it just means that somebody's on a ventilator, and it's the amount that stays in the lungs after exhalation, similar to CPAP. So what is CPAP? It's pressurized air that, like I said, is continuously given, no matter if you're taking a breath in or pushing a breath out. So I like this picture here because CPAP is basically, if you're ever ridden down the road in a car and you stick your head in the window and you feel that air get pushed in your face, that's what CPAP is. It's using this pressure to split open the airways. That way gas exchange can occur easier, oxygen stays in the lungs longer, and it kind of eliminates that obstruction in the airways that's caused by whether that's COPD, whether that's sleep apnea or obstructive sleep apnea, those types of things. So just at baseline, our lungs naturally have 5 centimeters of PEEP in them or of CPAP in them at all times. So setting the pressure anywhere lower than 5 is doing no good. Even setting one at 5 is not doing much. You really need set pressures of 6 and above to actually have it do anything, be productive for your patient. Let's see, this allows for the alveoli to not fully collapse as well. So you're not only are you splinting the larger airways, you're splitting the main bronchi and the segment bronchi, you're also splinting the alveoli open for a longer period of time. So that just allows more oxygen to diffuse across the alveolar capillary membranes. And then it prevents alveolar shredding when the alveoli get reopened with the breath. So the reason we have a natural PEEP is that if we didn't have this at baseline, all of our alveoli on exhalation would collapse. We'd fold in on each other, kind of like, you know, a sack of grapes getting smashed on each other. And then when you reopen them, they would shred apart, and that would cause a lot of damage. So it prevents that from happening basically all throughout our lungs. Indications for CPAP. We talked about sleep apnea. You can any other obstructive disease, whether that's COPD or asthma, that can be used for that really. CHF exacerbations, pulmonary edema, which is similar to CHF, atelectasis, and pneumonia. So the thing to keep in mind for anybody who's not aware, CPAP will not help clear carbon dioxide. So all it's basically used for is for oxygenation and obstruction purposes. If you want to actually make a difference in your carbon dioxide levels and your pH on a patient, you really need BiPAP, because CPAP will not actually help augment ventilation. It just wants open the airways. So it's not going to change how much air is moving in and out of the patient's lungs at any given time. You need two different pressures for that, and that's where you get into BiPAP. Let me make sure I'm not leaving anything out for you guys. Okay, so any contraindications to this? A lot of these are kind of general contraindications rather than an absolute hard and fast stop, but confusion or lethargy, inability to kind of use it, those are kind of general contraindications. With these, CPAP or BiPAP, the patient must be able to protect airway, which is why a lot of times we end up moving to mechanical ventilation after a trial of CPAP or BiPAP. On CPAP, at least all of our machines, or basically every CPAP machine, there's not going to be a backup respiratory rate. So that means if the patient goes completely apneic on you, it's not going to do anything. There might be an alarm thrown off, but it's not going to kick in a backup rate because it only has one pressure for the whole time. Whereas a BiPAP has the ability you can set a backup rate so that can kick in, and it can simulate an actual breath by pushing and pulling pressures in and out of the lungs. So BiPAP's a little safer from that standpoint, but either of them, you really just need to have somebody that's kind of generating their own respiratory rates. They're also dangerous if you have a patient that is actively vomiting. Obviously, you're going to want to avoid it because that pressure is just going to push that vomit kind of back into their airways and cause an aspiration pneumonia. And then significant hypotension, which I'll talk about a little more in the vent presentation, but anytime you put positive pressure into the lungs, that's going to kind of decrease your cardiac output and can lead to farther hypotension. So just be careful there, or at least keep it in mind if you're placing anybody on positive pressure. Issues that we run into with our machines and the home machines that people bring in is mostly air leak is probably the biggest one. Most of our machines, the V60s, which I know we aren't really using as much anymore, but most of the hospital standard CPAP and BiPAP machines are able to compensate for up to a certain amount of leak. Usually that's like 50 or 60, I think it's in mLs, I don't know, milliliters or something like that per breath. So you definitely want some leak. If you have zero leak, that means the mask is on too tight, and that's actually kind of dangerous. You want a little bit of leaks. And the machine, just through the way it's set up and the tubing, can actually sense however much of the leak it is, and it'll compensate to make sure the patient's still getting the pressure that they need or the tidal volumes that you want. And then, yeah, if it's too much of a leak, just adjust the mask, adjust the straps. Most of our masks in the hospital they have tabs on the side, which make it easier to take on and off. Most of the RTs would prefer if you don't actually adjust the Velcro on them, because then you have to reset that and play with it. It's easier, like if somebody just wants off for a drink or maybe to go to the bathroom and stuff, just pop the tabs off. And I'm making motions like I'm popping the tabs off and nobody's seeing me really here, but that's the easiest way to do it. And that way your strap settings kind of stay where they're at, and then you can pop them back on. Skin breakdowns, another issue, especially for those people that are using it pretty continuously for a long amount of time, several days, up to a week or so at the time. They can get some skin breakdown on the bridge of their nose. Claustrophobia is another big issue that I'm sure everybody's ran into with this. We do have other mask options that are available rather than the standard ones that fit around the nose. So we have like a full face mask. We don't use it too often, but I've seen it. I mean, I've used it before, and it does work pretty good for those patients that are claustrophobic. That way it goes around the eyes and they don't feel like their eyesight is getting blocked. And then we also have the nasal pillows, which are kind of work better for CPAP, not so much BiPAP, but they just sit in the nose and patients can breathe on them. The reason they don't work for BiPAP is because if somebody's opening their mouth, or especially a mouth breather, if they're just sitting in their nose, then you're going to be losing a lot of air pressure out of the oropharynx. And then you can cause pneumothorax. I don't think I've ever seen a pneumothorax caused by a BiPAP. You'd have to be pretty not incoherent, that's the wrong word to use, but you have to be not paying attention pretty much to cause a pneumo from a BiPAP. Let's see, so these are the 4 different ways that CPAP or BiPAP, you can apply this to both, kind of helps. You decrease the airway resistance, increase lung compliance. So that's interesting. Sometimes people think that positive pressure would actually make it more difficult for somebody to breathe, or their lungs would be less compliant because now you're holding them open. But the way I think of it, and I was taught, if you've ever tried to blow up a balloon, it's really hard at first until you kind of get it started. And then from there, that balloon will expand a lot easier on you once you get past that first kind of initial resistance point. That's what I think about when I think of CPAP and actually helping the lung compliance. And then let's see, it increases your pressure gradient. So alveolar capillary membrane, it can help there. And then your surface area, just because you're stenting open more of the alveoli, so there's more actual area available for gas exchange to occur. Go on to the next slide here. So I'm kind of going to go through each one of those 4 in a little bit more detail, just so everybody gets a little bit better of a picture. So air resistance is, by definition, the resistance to flow caused by friction within the airways. So that's usually, when people are talking about this, they're usually talking about the upper airways rather than lower airways, because most people's lower airways, their anatomy is pretty much the same, but the upper airways varies from person to person. This is what happens in obstructive sleep apnea. You actually get a blockage in the upper airways, and that's where most of the obstruction occurs. So positive pressure helps augment that. A lot of times with people sleeping, it's because their tongue is falling back in the posterior pharynx. So that kind of causes your turbulent airflow. Lung compliance. So there's actually, it's how well or how easy the lung expands. So if you again, blowing up a balloon, some balloons are really difficult to expand when you blow them up. Others just pop open for you, depending on what balloon you have. So that's how I think about lung compliance. It's just how expandable is the lung for a given amount of pressure. So the equation is the change in volume over the change in pressure. So for any given pressure, how much volume does that put into the lung? That's how you measure compliance. So if it's taking a lot of pressure and you're only getting a little volume, that number is going to be smaller. And then opposite to that effect, if you're getting a lot of large volume and it's still not taking very much pressure to achieve that volume, your compliance is going to be a lot higher. So the way CPAP and BiPAP work is they kind of keep pressure in that lung, so your change in pressure doesn't have to be as great to achieve the same tidal volume. So your clients will be better from that standpoint. Let's see, pressure gradient. Oh, another good example of lung compliance is like for you guys who are nurses, if you've ever like bagged a patient during a code or something. Some people are very easy to bag because they have super compliant lungs. Other people, you have to really squeeze down that bag to feel like you're getting any air into their lungs. That's a good way to think about compliance. And then the pressure gradient is the difference between a higher pressure concentration and a lower one. So gases will always move down the pressure gradient. They always want to achieve normal, like equilibrium, I guess, all things equal. So oxygen this is how gas exchange occurs in the alveolar capillary membrane. So O2 enters the blood because in the capillaries, there's less oxygen in the venous capillaries. The blood returns to the lungs. They have a lower amount of oxygen, whereas actually in the lungs, there's a higher amount of oxygen in the air at the alveoli. So it's going to want to cross that pressure gradient, move from area of higher concentration, the lungs, into an area of lower concentration, which is the blood. And then CO2 is the opposite. In the blood, because it's already been used by the body, it's returning to the lungs. It's going to want to cross from that higher concentration into a lower concentration. Bipap helps us with that. This is getting into the weeds. I'm not going to go into all the numbers here. There's a lot of math that can go into this, figure it out, physics, everything like that. Basically, I'm not going to go into that. Let's see, I think that's it. Oh, surface area, sorry. So if you were to like flatten the lungs out, basically it would roll them out with a rolling pin, whatever, it would equal a tennis court, which I always thought was kind of cool. That's huge to me. And then it's all folded up into your tiny little chest compartment. So surface area is how much of the area inside your lungs is available for gas exchange at the alveolar capillary membrane. So things that will decrease surface area are things like atelectasis, pneumonia, fluid in the lungs, those types of things. They all decrease how much surface area you have available for the gas exchange to occur. So when we use CPAP, it just helps keep those open so that you have a larger surface area. Let's see. This is just about starting it. This isn't too in depth. Usually when we start CPAP, we want to start at a pressure less than 10 centimeters and then kind of titrate up as needed. So it's like with any other medication, use the least effective dose possible and then kind of titrate it up or down if you need to. You don't want to use too much of a pressure because you can actually cause damage, over distension, and then you can lead to that hemodynamic compromise I talked about if you have too much pressure in the lungs. And then do the same thing. Okay. I'm going to move on to ventilators. How do I get there? Maybe you guys have questions before I go on.
One moment, guys. Been helpful if I would have saved this when you sent it to me.
It's supposed to be done at 3.
Ish. Come on.
All right. We'll talk some vents here. All right, so just basically as a review, just covers some anatomy of the lungs. You have trachea, which then splits into your primary bronchi, right and left, which then splits into farther subsegmental tertiary bronchi and subsegmental bronchi from there. You have 3 lobes on the right side, the superior, middle, and lower lobe, and then with 2 fissures. So there's a fissure in between each lobe. You have the horizontal and the oblique fissure. And then on the left, there's just 2 lobes with an oblique fissure in between. And then, so your lungs basically have 2 layers. You have the, let's see, there's, well, 2 layers with a pleura in between, I guess. It's kind of similar to the heart where you have separate layers. And that inside that pleura is basically a negative space, like a vacuum in there. So we want to keep that a negative space. If anything gets in there, it causes issues. Yeah, I don't think I have. And then you have, at the end of all the bronchi, they terminate in the alveoli, which is where the gas exchange actually occurs, at the alveolar capillary membrane. I have pictures of that later. So first, we'll talk about spontaneous breathing. So this is just breathing without the use of a machine. So you're in your brainstem and your chemoreceptors. Those are the main places that control your breathing. There's many different muscles involved. So on this picture, if you look at what they label as principal muscles of inspiration, these are the ones that you just use at baseline, just when you're sitting here in a room breathing with, comfortable, things like that. So you have your intercostals, the external ones primarily, and then you have parasternal intercartilaginous muscles, and then your diaphragm's the primary muscle of passive inspiration. Not passive, but non-principal inspiration, I guess I should say. And then your accessory muscles are when you're having a difficult time breathing, you're trying to take extra large breaths. Maybe you've been running a marathon, something like that. So your sternocleidomastoid muscle will kick in, and that's when you can see people with really distended necks trying to breathe very hard. You can especially see that sometimes in kids, where their head bobbing a little bit because they're using those muscles. And then the scalenes, you use a little bit up in the shoulders. And then expiration, on the other hand, is a passive motion. So you actually don't use any muscles to expire your oxygen or your air. It just happens naturally. So if you do have an obstructive situation or something going on, some kind of process going on in the lungs where you can't expire naturally, then you do have to use some muscles to kind of push that air out. So here you would be using your intercostals, some of your abdominal muscles, things like that. And this is where they talk about belly breathing and COPDers, because they're actually having to use those muscles. They're contracting in order to push that breath out a lot of times. So spontaneous breathing creates a negative intrathoracic pressure. So with that diaphragm pulling down, it kind of creates a vacuum within the thoracic cavity in order to pull that air from the outside world into your lungs. The good thing about this is that when it happens, when that vacuum occurs within your thoracic cavity, it also pulls blood in addition to the air into your lungs. So this makes it a little easier for the heart and everything like that, and for the blood to get into the lungs. That way that diffusion can occur. Now, if you kind of compare that to mechanical ventilation or CPAP or BiPAP, any of the other modalities that we use, these things all create a positive intrathoracic pressure. So this comes into play when we're talking about hemodynamics. This positive pressure will actually decrease your preload, increase your afterload, and then overall, basically, it decreases your cardiac output, because now all of a sudden you've basically increased your TPR or your SVR within the thoracic cavity. So now all of a sudden the heart's having to push against a higher level of resistance in order to get that blood from the heart into the lungs for diffusion. This picture here is really good. You can see the first alveoli on the left is kind of like a natural one. It's not over distended. You're using the right amount of PEEP, or the patient's just naturally breathing. However, if you put too much PEEP in the lungs, or too much pressure, you can over distend that alveoli, and what happens is those alveoli get distended and they kind of compress the capillaries. And if you do that throughout the entire surface area of the lungs, that leads to a lot of resistance for the heart to pump against. So this puts strain on the heart. It really becomes important to pay attention to whenever you have an issue with the right side of the heart, like a right-sided MI, or any other kind of cardiomyopathy with the right side of the heart, because in a lot of people, the right side of the heart is able to kind of overcome this increased pressure. So you actually won't drop your pressure. Usually you're all right. The right side of the heart can, like I said, overcome that. You can maintain your pressures. It can push against that. If for whatever reason, the right side of the heart can't compensate for this increased pressure, then overall your systemic pressure, your MAP and everything will start dropping, because all of a sudden the blood's starting to back up in the venous system through the vena cava and things like that. And now all of a sudden you don't have blood going from the right side of the heart to the lungs. And then from there, you don't have blood returning from the lungs to the left side of the heart. So your systolic pressures will start dropping on you. Let's see, make sure I don't miss anything. All right, go to the next one. So the alveolar capillary membrane, this is where ventilation really starts at. Up until this point, all through the bronchioles, things like that, those are just pathways for the air to get down to the alveoli. No actual gas exchange occurs in the bronchioles at the alveolar level. So in a healthy lung, oxygen, CO2, those are able to pretty much freely move back and forth from the alveoli to the capillaries, and from the capillaries back to the alveoli. It doesn't take a lot of extra force or a lot of extra pressure or anything like that. So for issues that you can get in is, one thing I want to make an example of, if you're running a marathon, let's say you go out and you exercise, all of a sudden now the blood flow through the capillary is flowing a lot faster. So the oxygen now doesn't have as much time as it had before to get from the alveolar to the capillary. So more red blood cells are going by, not as many of them are getting oxygenated. So that's going to, if that happens over time, now all of a sudden you need to generate more oxygen to keep up with that faster blood flow in order to compensate for it. So what do? You start breathing quicker in order to exchange more oxygen, get more fresh oxygen, keep those numbers higher in the alveoli, I should say. Also, so that's one thing that can happen. There's a lot of disease processes that actually create kind of a blockage at this level. So I was talking about this in the CPAP presentation a little bit. So ARDS and pneumonia and fluids, those all, I wish I could show people, those all create a blockage right in here. So now all of a sudden in this O2 that could easily move across, there's something in between it, and now at this alveoli, it can't move across. So now all of a sudden it has to find another way around, or it just gets exhale breath, and the oxygen from a different alveoli has to diffuse into the blood. And now all of a sudden this blood is not getting oxygenated, and the CO2 is not getting out also. So it creates a blockage on both sides of things, and then your CO2 levels start building up. This is how you get these processes lead to hypoxemia, hypercapnic problems, those types of things. All right, so I want to get in the basics of ventilation. We'll start with FiO2. So this is just the percentage of air that's made of pure oxygen. So at room air, everyone here is breathing 21% oxygen. We can set this on a vent. It's nice because we can control the exact amount of oxygen we want to give to the lungs, from 21 up to 100%. FiO2 basically, if you look at this picture before, instead of one oxygen here by the red arrow, now all of a sudden, if let's say you had one oxygen with 21% FiO2, now if we increase that we double it, let's say we put them on 42%. Now it increases the amount of oxygen available to diffuse across that membrane. So it just gives you more numbers of oxygen in this. Whereas PEEP is pressure. So this is how much air or pressure is left in the lungs after exhalation. We talked about that with CPAP. So basically it splints the airways open so that the oxygen can stay in there for a longer time. So it doesn't give you more oxygen, it just lets whatever oxygen is in there stay in there, hang out for a little bit longer until it's ready to cross the membrane or able to cross the membrane. That way you're still increasing how many oxygen get into the blood. Like I said, a downside of PEEP is that you can over distend the lungs and squish the capillaries, cause that increased strain on the right side of the heart. So that's kind of when we start talking about optimal PEEP. How much PEEP are we able to give the person to produce the maximal amount of oxygenation without creating hemodynamic instability? There's a lot of things and modes and I don't know, techniques coming out, especially within the last 5 or 10 years on different vents and from different companies to measure optimal PEEP. And there's a lot of studies going on with them. There's no hard set in stone way to do it yet, unfortunately. But you guys, I mean, everybody can read about that on their own. Dr. Pardinas might go into it a little bit. Let's see. And then respiratory rate and tidal volume, most people know about. It's just how many breaths per minute and volume of air in each minute. So your tidal volume and respiratory rate are going to be the two things that control ventilation and control carbon dioxide elimination, whereas PEEP and FiO2 are primarily resources to control oxygenation. Okay, so here's where I got into, I guess, over distension a little bit. So the alveoli squishes the capillary. This puts strain in the right to the heart and decreases preload. So we already talked about this, but like I was saying, there's a lot of different techniques. This ARDS table is down here. That's kind of been, I don't know, I forget what year that came out, early 2000s, I want to say, but it had kind of been the standard for a long time when we didn't have any other way of determining how much PEEP to give a patient. Let's say somebody's on 80% FiO2. What do you set the PEEP at? You set it at 5, 6, 7, 8, 9, all the way up to 10, 15, 18. A lot of physicians were doing it differently. So this kind of standardized it a little bit better, so that a lot of physicians were more on the same page. Now there's a lot of other different options, such as volumetric CO2, which is actually, instead of measuring end-tidal CO2, it's actually the volume of CO2 being exhaled. We have pressure volume loops. We have esophageal manometry. We don't use those on a lot of our vents here yet. I expect in the future we will be starting to get some of these modalities. You'll probably start to see them come into play a little more in the next 5 to 10 years. Potentially if we ever get any other vents besides the ones we have now. But I won't, I'm not going to spend all day lecturing on those. Those could each take 20 minutes or more on their own. So I'll move on to ventilator pressures. There's a couple different pressures that we look at. So plateau pressure is the end inspiratory pressure. So this means that you fill the lungs up, you do a hold, there's no air movement in or out, and then it measures the amount of pressure in the lungs there. So our goal is usually to keep it under 30 to prevent over distension, or especially in ARDS when people have less compliant lungs. Those pressures are going to typically start to climb a little bit. That's where we start to get in trouble. And this is one way we can help kind of determine the compliance. Whereas in contrast to that, a peak airway pressure means the maximum amount of pressure, whether that's at the end of the breath, in the middle of the breath, during the breath hold. Usually it's going to be as the air is going into the patient. So this is, the vent automatically measures this. You don't have to do any special breath hold or anything like that. It's measured during air movement as it's, like I said, as it's going into the lungs. Let's see. So down here at the bottom, I want to talk about the relationship between the two. Usually if plateaus pressure, usually your peak pressure is going to be higher than the plateau pressure, okay? As your plateau pressure rises, generally your peak pressure will rise in conjunction with it, usually at the same amount. So in any of these diseases like ARDS, pneumothorax, obesity, they'll kind of rise together. Sometimes that doesn't mean that your peak pressure can't rise on its own though. There are certain instances where your peak pressure can skyrocket, but your plateau pressure maybe still remains around 20 or 25 or in a normal range. These would be things that make it hard for the air to get into the lungs rather than an issue within the lungs itself. So a problem with the circuit or the ventilator or one of the valves on the vents, sometimes asthma, bronchospasms, a problem within the conducting airways. Maybe they've got a, well, if they're on the ventilator, they're gonna have a tube in their throat. So you're bypassing most of the upper airways. So it would usually be a problem either with the tube, the circuit, or the bronchioles. Those are your big things. Mucus plugging can do it because that happens in the bronchi. But rather than the plateau pressures rise when there's a problem at the alveolar level, such as ARDS and pneumonia and a fluid and things like that. So it's just something to keep in mind. It can kind of point you in the right direction as to what's going on. The new ventilators from Hamilton have like a picture of the lungs on them. And they kind of automatically, from what I understand, kind of are able to tell you guys whether it's an obstruct, like a plateau pressure issue or versus a peak pressure, and some things to think about. So they've got some visualizations to help people out. The auto PEEP, this just means when the patient is developing a PEEP, an increasing level of PEEP on their own rather than you or the practitioner or the nurse or the RT or somebody setting a higher level of PEEP. So this happens when the patient is not able to exhale all of the prior breath before the next breath is pushed into them. So let's say, like if you can imagine taking a breath in, letting it out, but only letting it out halfway before you take another breath in, and then doing that 20 different times, and every time you get more and more and more pressure in your lungs because you can't ever fully exhale it. That's what auto-PEEP means. This is because you get that obstruction, so it's turbulent for the air to get out of the lungs. It's really difficult for it to escape, especially if we don't have the settings set right. So you can get to air trapping because of that. And then some things we can do to fix it. You can slow down the respiratory rate just because that gives you a longer time to exhale before the next breath is given. And then also given a shorter I time, that way your expiratory time is longer. Like some of those settings like that. Yeah, I like this. These pictures kind of show it a little bit here. See, I can't really point out the things with a cursor here, but if you see on that middle line on the left, the picture on the left, middle line, that's the flow waveform, where those little yellow, they look like eyes almost, the arrows are pointing. That just means the expiratory flow is not getting all the way back up to baseline before the next breath is being pushed in. So generally you want to set your I&E time or your respiratory rate so that the expiratory flow comes back to baseline before the next breath is given. Otherwise, your flow, you're still having an expiratory flow. You're still basically saying you're still in the middle of expiration before the next breath is being given. So let's see, the picture on the right, I guess, shows that a little better. The first breath here, that yellow dotted line, it returns all the way to baseline. The yellow solid line does not, and that's where you're getting auto PEEP from. All right, and then, so we'll start talking about our actual vents a little more. So this is what you see on our servos. Across the bottom always is our settings, what we can set, and then always across the right-hand side are the feedback numbers, or feedback from the patient. Let's see. They're also color coded, up to note as well. The yellow is all your pressure readings and pressure waveform, and then green is flow, and the blue is all your volume feedback. All right. So there are many different modes of ventilation. I'm not going to go through every single one, but I'll hit on some of the most common ones. So basically, there's two categories. There's assist control modes, which is kind of like an umbrella term for a lot of different modes, such as volume control, PRVC, pressure control, those types of things. They're all technically assist control modes. They're all control because we set a breath. We set you set a rate basically, so that you set a rate so that you're ensuring that the patient gets so many breaths per minute. Whereas the spontaneous modes, such as pressure support, which is support modes, you don't actually set a respiratory rate. The patient kind of controls that on their own. The picture over here on the right is kind of just a good summary of all these different things. If anybody wants to look at it later, also I can send this out to anybody who wants it. Let me know. But I think it's kind of, from a nursing standpoint, kind of a good overview of everything. The ventilator basics. So we'll get into volume control first. So this one's not really used all that often because with every mode, you have something that you set, and then you always have another thing that's a variable. Well, in volume control, you set the volume. So you're setting how much volume, tidal volume, that the patient is getting with every breath. Well, on the flip side, that means you're sacrificing something, or something's going to be variable. In this case, your pressure is going to be variable. So it's a good mode because it can generate, or you can guarantee volume. So let's say you want to make sure for some reason that somebody has 450 every single breath. You can ensure it. But however, if something changes within the lungs, if their ARDS gets worse, if they develop a pneumothorax, if there's a kink in the tube, the pressures are variable, and therefore the pressures will go up, and you can cause issues such as barotrauma, or a worsening pneumothorax or anything like that from there. So it's not used all that much, honestly, because it is kind of an unsafe mode, I think. I think there are some people do use it in certain circumstances, but just with the risk of developing high pressures and injury to the lung, I think it's kind of fallen out of favor a little bit. Let's see. Yeah, so in any of the control breaths, let's say you set your respiratory rate at 10. This means they're going to get 10 breaths at whatever set volume you have every single breath for those 10 breaths. If the patient is breathing 10 times a minute and you have the respiratory rate set at 10, let's say you set it at 10 and now the patient's waking up a little more, they're breathing 12, 13, 14 times per minute. Well, they're still going to get your set volume with every single breath. So now your minute ventilation is going to change, and they're breathing more per minute, and then they can develop respiratory acylosis from there if they are breathing over your set. So just something to be mindful about. We'll move on to PRVC. Did I skip? Oh, okay. All right, PRVC is probably our most commonly used mode here. Some providers prefer it more than others. Basically, you set a tidal volume, so it's similar to volume control. However, it's got a safety net, which is the pressure regulation. So it tries to deliver whatever volume you set. However, if it reaches that pressure regulator, whatever you set, let's say you set the pressure regulator at 40. Well, if you're trying to give a 400 tidal volume and the vent's given 300 and you're already at that pressure of 40, it's just going to cut the breath. That way you don't exceed that pressure limit. So it's a little safer than just straight volume control. That's why we use it more often. The downside to it is that it can cut that breath, and sometimes it won't you won't know that it's been cutting breaths. So let's say you, as a provider or a nurse, you're not in the room for an hour or two, and you come back and all of this sudden the patient's more acidotic or more lethargic, their CO2 levels got up, and you don't even know because it's cutting the breath every time and it's not telling you. that's kind of the downfall of this mode, but in general, a lot safer than volume control. Let's see, pressure control is another very commonly used mode. Similar to volume control, except that this time the pressure is your control. So you're setting a desired pressure, and however, now your volume is going to be inconsistent. So it's the variable. So let's say you set a pressure control of, let's just say 20. All of a sudden, or initially, let's say you're getting tidal volumes of 500 and everything looks good and fine and peachy. And then all of a sudden your patient decompensates and now you're only getting volumes of 200, and you don't know it because you haven't been in the room for the last couple hours. You haven't been paying close attention. Or maybe you're just starting this morning and you don't know what kind of volumes they were receiving earlier, and overnight they decompensated. So now all of a sudden your ABG is thrown off because your tidal volumes are half of what they used to be, and the event wasn't alarming because it's still giving you the same pressure. So that's the downfall to this mode, but it is a lot lower risk of causing any trauma to the lungs because you're controlling that pressure, and you can basically control your driving pressures, which is what a lot of studies and recommendations use for determining optimal ventilation for ARDS. So I'm sure during COVID we used it quite a bit, at least from what I saw. I think I wasn't here for the first couple of years, but I'm sure it was used quite a bit more than we ever used to use it. Move on to SIMB. Here you are setting a volume and a rate. The only difference between this and like pressure control or volume control is that on the extra breath, let's see, you can add pressure support to it. That way the patient gets like, probably it's not the same as the volume control breath. So you're giving so many breaths per minute of the SIMB mode, but then you're setting pressure support on top of it so that it's kind of like a weaning mode, basically. They use this a lot of times in PACU because as the patient becomes more interactive, it kind of automatically transitions them over to more and more pressure support breaths. So it's kind of doing some of the weaning for you rather than they're just on volume control or pressure control or PRVC, and you have to watch the patient and then switch them over from that mode all the way to pressure support. This can be kind of 50-50 SIMB pressure support at the same time, depending on how quick or slow the patient's breathing. We don't really use this in the ICU a ton. I've seen it used before, but not all that much because your volumes vary with each breath. It's hard to standardize it. Your breaths are at a certain volume, and then some of them that are the pressure support breaths are at a much less volume because the patient's only generating a little bit of tidal volume, not quite what you have it set at. So just pretty variable. That's why it's used in PACU a lot more, or anybody that sometimes if people are trying to wean and they're not quite ready for pressure support, but they don't really need to be on PRVC. It's kind of like a middle ground type of mode. And then pressure support is our primary weaning mode. We use this for spontaneous breathing trials. With this mode, the patient has to be able to trigger every single breath. And then when that vent senses that the patient is triggering the breath, it'll give whatever pressure you have it set to. So your volumes will vary as kind of this graph here on the right shows, and your flows will vary, and it's just not very standardized, but it most accurately kind of simulates our own natural breathing pattern. And it's the mode that's most comfortable for patients who are awake and alert and responding to you. And I think this is the last slide, I'm not 100% sure, but extubation, criteria for extubation, you want to make sure you address whatever underlying problem is, whether that's ARDS, pneumonia, those types of things. Secretions are controlled, so you don't want to extubate anybody that's having difficulty clearing them or protecting their airway. Relatively stable hemodynamics, and then a patient's able to follow commands, squeeze your hands, open their eyes, sit up in bed, those types of things. Cuff leaks are variable from provider to provider, whether they're actually beneficial or not. I would say most commonly times that people use them is for like anaphylaxis patients because there's a lot of swelling going on. So basically you let air of the cuff, make sure that a leak's present or there's a leak going on around the tube, indicating there's no airway edema, up to the tube. You want to make sure that the difference between inhaled and exhaled tidal volume is at least 100. I think that should say less than 100, sorry, less than 100. You don't want a large, or no, sorry, we're doing a cuff leak. Yes, you want a large difference between your inhaled and exhaled. That meaning there is an actual leak going on and air is able to escape around the tube. And I think that is it. Yeah, that's it. 303, not too bad. All right. Any questions from you guys? Yeah. Hopefully that was helpful to you guys. I know it wasn't super in depth with anything. I know Dr. Pardinas is giving one tomorrow that's supposed to be a little more in depth from my understanding. This is kind of just for a basic overview, kind of general understanding of some different vent modes and things like that. Thank you. All right. Thank you, everyone.